morning. It's a pleasure to be here. I'd like to thank Val for organizing this, and I'm a Mac guy operating a PC, so we'll see how that goes. But it's great to see so many familiar faces in the audience, especially without a gown on. So, and I'd like to thank also, Val, first of all, just a little word about Val. I think Val really has done an amazing job setting up the Aim at Melanoma Foundation. And really, she's really devoted to this cause and this disease. And really, she's, I think, the top patient advocate that we have in melanoma in the country. So, and we in the Bay Area are very lucky recipients of the fact that she lives here. So, and we are recipients today of the largesse of the foundation of being able to conduct this seminar here. So, really my thanks to Val for all of her efforts to promote melanoma education, research, and really trying to help melanoma patients worldwide. So. What I wanted to talk to you about is some of the work that actually we've been doing, an area of research that I've been focusing on over the last maybe 5 years or so, which is the development of what we call biomarkers for melanoma. And so the first question that would come up is, what is a biomarker? And this is my own definition. I didn't look it up in a textbook or anything like that. And a biomarker is anything that you can measure that measurement can then be correlated or associated with some aspect of a disease process. And it could be anything. So as this example I've sort of come up with here, I'm a big fan of shoe size. So, if we had some research, for instance, that anybody with a shoe size greater than 8, completely survived their melanoma, then shoe size would be a biomarker. We could use that to predict what's actually going on. But usually, of course, we're not using things like that. We're using either clinical factors, like age, gender, where the melanoma is, the location, for instance, a histological factor, how thick it is, many other factors that we look at, or more recently, molecular factors, any molecule that can be measured. And usually we have 3 different levels that we can measure a molecule, either at the DNA level, if we have more than 1 copy, so the number of copies of some gene could be important, or when that DNA gets translated to RNA, how much of the RNA do we really have? Or ultimately, when we get to the protein, if we have a lot of it or a little of it, does that really associate with some aspect of a disease, and in this case, obviously melanoma? So that's what a biomarker is. Now we have different types of biomarkers. We want them to do different things for us. And sometimes they don't all, each one of them don't do all of these things. We need different biomarkers for the different, really, questions that we ask in the clinical arena. And so in general, we have 3 kind of major types of biomarkers: diagnostic, prognostic, and predictive. And what are they? Well, diagnostic, as the name sounds like, well, it's helping to make a diagnosis of malignancy, because we're talking about cancer. And in melanoma, it would try to distinguish between a mole, a benign mole that we all have, versus a melanoma. So that's a diagnostic marker. A prognostic marker, is, prognosis is what's going to happen. What's the risk that I have associated with my cancer, in this case melanoma. So a prognostic marker can increase or decrease the perception of risk, and may affect the willingness to accept certain risks for certain treatments. So we would say, well, because of this marker being present, or because of this marker being present at a higher level, my risk is higher, therefore I should do something about it. And for instance, it would determine low risk versus high risk patients in a certain situation. And that might have implications for how we want to treat that particular patient, or it might have implication for the patient. What kinds of side effects, what kinds of treatments would I want to accept? Because what's my risk? And then the third one is a predictive marker. So here, this marker would predict response to a particular treatment. So because this marker is present, I might be able to get this particular treatment. And so these are all very different. Just because something tells us it's a melanoma doesn't mean that it tells us that that is a higher risk melanoma. Just because something is a higher risk melanoma, therefore a prognostic marker, doesn't mean that somebody's going to benefit from a certain type of treatment. So we need all three of these types of markers out there. I'm going to focus my discussions really on the first two because our other speakers are going to talk more about treatment and so the predictive markers. So you might ask, why do we need biomarkers? Well, as we mentioned, and specifically I want to talk now about melanoma, but as we talked about briefly, biomarkers can help us in making decisions about diagnosis, prognosis, and treatment. Now in the diagnostic and prognostic arenas, why could this be important, or why might there be utility to this? Well, some melanomas can actually be hard to diagnose. And it turns out that in a number of studies that have been done, if you take the same biopsy slide from a patient and send it to a bunch of different pathologists, there can be a high degree of variability in the diagnosis of melanoma. And it can be somewhere between 15 to 30, maybe even as high as 40%. So having something else, and those are the patients who incidentally wind up in our clinics where we don't really know what the lesion might be, what the spot might be. And we have a lot of cases where 2 or 3 different pathologists have looked at something and they may not agree on what the diagnosis really is. And so here, if you had a biomarker that can help, it can really tell us, okay, is this really a melanoma or not? And then we know what to do from that point on. And if it's benign, well, of course, we would leave it alone. In terms of a prognostic marker, why do we need those? Well, predicting the behavior of melanoma is difficult. Predicting anything, like the weather, of course, is very difficult, but predicting what's going to happen to an individual patient is very, very hard. And so the more tools we have, hopefully the better we're going to be at doing that. And again, of course, with melanoma, predicting which ones are destined to spread and therefore need treatment is hard. And the more tools we have, the better we're going to be as physicians, and the better we can help our patients. And so what do we have right now? What's the current status of melanoma biomarkers? It could be a short slide, but I'm going to take a little bit longer to discuss it. So in diagnostic, we don't have any markers that are currently available that we use every day if this dilemma comes up where we're not really sure what we're dealing with. And things are being developed, but there's nothing out there right now that we would say, okay, we're going to use this 100% of the time. And with a prognostic, again, we have no markers that are available that can accurately predict the prognosis of melanoma, and especially better than routine factors that we use, like thickness of the melanoma. And a key question in this whole biomarker field is, once we identify these biomarkers, it's great, we sort of slap each other on the back, but the key issue is, do they really add anything to the knowledge that we already have from the routinely available information? Are they really making us any better, or are they just fancy tests that aren't really going to push the envelope? And so we've gotten interested in this, and we've been interested in this for quite some time. And melanoma is really a very interesting scientific model because of the fact that it goes through various stages that we can see actually on the skin, and then you can look at it under the microscope, and then you want to study it in the laboratory. And this is very unique in a lot of the cancers because we can actually see some of these. So we start out with the melanocyte. I don't think we have a pointer, but you can see the melanocyte at the top. And this is just a benign pigment-producing cell. And now when that melanocyte grows, you go to the nevus, the sort of right-sided hash mark, and a nevus is a benign mole. And then from there, that mole can turn into a melanoma. And there are 2 phases of a primary melanoma on the skin it can turn to. The first phase, and this is the most common type of melanoma, it can go through a radial growth phase where the melanoma is kind of growing on the surface. It's a flat spot that's kind of getting bigger and darker. And then eventually we can get to the next phase, what we call the vertical growth phase, where it becomes more bumpy and it's growing into the skin. and then ultimately it could potentially spread. And so these are the things that have been described, and now the question is, do we have biomarkers? Can we assign markers to each of these stages of progression of melanoma? Because the idea is that if it goes from one stage to the other, this holds potentially a key to our understanding what's really going on, what's really making melanoma tick. And so, you know, when we started looking at this kind of genetically about 5-6 years ago, you couldn't really assign any genes that you could say, you know what, this helps distinguish this stage from this stage. And we're going to hear a lot about BRAF, you know, which has become a very exciting area in melanoma. We've seen that this gene called BRAF can be mutated in melanoma. It turns out, and it's being used for treatment, and we're going to hear about that, and it's a very exciting development. But when you look at it from a biomarker standpoint, it turns out that the BRAF mutations happen at the level of a mole. They happen very early. So they don't really distinguish between these other stages. So we do need other markers because BRAF is not diagnostic. BRAF is not prognostic, but BRAF, it's looking very much like it's going to be predictive of response to a particular type of treatment. And so we started to address this, again, published about 5 years ago, with a technique called gene expression profiling. And I'm not going to bore you with the details, but basically we looked at the whole gene, you know, the whole genome, which was about, at that time, we could look at about 20,000 genes using something called a microarray or a gene chip. And you're looking at all of these thousands of genes at the same time, simultaneously in a spot, and then you're comparing these spots and seeing which genes are up and which genes are down. And we looked at some of those checkpoints that I showed you before. Moles, primary melanomas, and metastatic melanomas at the genetic level. And this was really the first time that this had been done. And we identified a lot of genes that were up or down. If you compare nevus to primary melanoma, the radial to vertical growth phase melanoma, or primary to metastatic melanoma. And so then we kind of postulated that, okay, we found all these genes, and we bet you these genes are going to be useful for something. But we hadn't really proven that they're going to actually help us in any kind of clinical scenario, but at least we identified the genes that might be of some utility. And the next 5 years focused on trying to figure out which one of these genes actually could help us in some of these situations. And so more recently, we developed what we call the Multimarker Diagnostic Acid for melanoma. And so how did we do that? So we took 700 cases that were either moles or melanomas, and we, from the hundreds of genes that we had found being up and down between moles and melanomas, we took 5 of these markers, 5 of these genes, and here are the names. And we're not going to go into them in a lot of detail. I'll mention a little bit about each gene in the next slide. And our pathologist, Dr. Segabil, many of whom you know and met, we tested these spots, the moles and the melanomas, for these markers. And he was the one who had to sit there and say, oh, this marker is up and this marker is down. And we sort of used a very simple 0 to 3 scale. 0 meaning absent, 1 meaning, oh, it's there slightly, 2 meaning moderate, and 3 meaning, gee, it's really hot, it's really there abundantly. But he also noticed that, you know, it's not just how much of it you have, it's where you have the marker. So we started looking at it at the top, you know, and the bottom of the mole or the melanoma, because it looked like, gee, maybe there's sort of a gradient here. And then we had a statistician that analyzed this and developed an algorithm, kind of a tree, a classification tree, to help diagnose melanoma. And then each of these spots was given a diagnosis just based on the marker. So you now have a molecular diagnosis, and then you compare it with what the original diagnosis was, and you see how accurate your markers and your assay is. And so the markers that we looked at, these are the ones, and I don't want to dwell a lot on them, but one is called ARPC2, and it's what we knew about is some of these markers were completely new. We didn't really know much about them in cancer or even about them in general biology. This particular marker, the only thing we knew was that it helps cells move, you know, not necessarily cancer cells, but cells in general. And we thought, well, this is kind of interesting because maybe it's helping cancer cells invade, you know, into other structures. But this was really the first time this had been looked at in cancer. And then another gene called FN1 has been shown to promote melanoma invasion and actually spread. So this was a known gene that other people had looked at. And this gene called RGS1, again, had never been studied in cancer before. So this was the first time we had looked at it. And then two other genes, SPP1, which is known as osteopontin, and WIN2, that had been shown to be involved in melanoma. So some of them were plausible, and some of them were completely brand new. And so this is what our pathologist sort of saw, Dr. Segabil, was that when you look at the nevus, you know, what you can see at the top is the brown stain. I hope you can see the top part is completely brown. And this is for one of these markers called WIN2. And what he saw was that when you go from the top to the bottom of the mole, you lose the brown. The brown is where the protein is. So in a mole, it lost expression down at the bottom. Now when you compared it to panel B, where you have the melanoma, the expression was completely uniform. So just this pattern of expression could be used. Anybody could look at that and say, gee, you know, I can tell the difference. And one of the types of growths that we looked at were what we call melanoma arising in association with a nevus, or what I've called here a melanoma that's growing out of a mole. So you have a mole and it started turning into a melanoma. And we thought this was really nature's perfect experiment, because you had the mole and the melanoma side by side, and the question is, how good are our markers can they pick them up when they're literally residing right next to each other? And hopefully you can see that the M, the top part, is brown, and right next to it is the N, is the nevus. So the M is the melanoma, and it stains brown, it's got the marker, and the nevus is completely absent. So even when they're sitting side by side, you could tell exactly, you know, where the mole stops and where the melanoma starts. And so then, you know, you have to do some statistical analyses to say kind of how accurate is this. And so first I want to go to the bottom, some definitions. So we talk about things like, and you might have heard these because we use this for everything in medicine, sensitivity, specificity, and then something called AUC. And sensitivity stands for the number of lesions, growths, that the assay diagnosed as melanoma over the number of known melanomas. And so the higher, obviously, your assay, the better your assay is, the more sensitive it is as picking up the melanoma. Specificity is the other side, is how many did your assay correctly predict as moles? The number of moles over the number of known moles. And so when we look at, and we looked at different ways, but if you just look at what's in bold, the combined scores, the assay had a specificity of 95% and a sensitivity of 91%. And now with the AUC, this is what is known as area under the curve. You're trying to see how much of the knowledge curve, if you will, can you fill up. And a perfect AUC would be 1. And so what you'd like to do, and with these numbers, the way I think about them is just like being back in school. You know, if you're in the 70s, you're doing okay, it's a C. If you're in the 80s, you know, you're pretty good, and if you're in the 90s, you're very good. And the reality is many things that we, you know, use in medicine have a sensitivity and specificity in the 70s. A lot of stuff that we're using on a day-to-day basis. If they're really good, they're in the 80s, and when we get to the 90s, we start feeling pretty good. Although, of course, we'd like to be perfect, but no test is perfect. So these gave us some confidence that we're breaking, you know, the 90 barrier in sensitivity, specificity, and also this AUC thing. And this is another way to look at the AUC. So you draw these curves, and you're trying to see how much under the curve are you filling out. And the best case scenario would be that, you know, you have a curve that goes up and to the right. So you filled out this whole panel, that would be a perfect test. And so what we wanted to see was, do we really need all 5 markers? And you can see that yes. You know, if you just use 1 marker, you're not that good. And when you add 2 more, you get to the second curve, and when you add all of them together, you get the best results. So it looks like melanoma is kind of complicated, and you can't really just have 1 marker that fits for every type of mole or melanoma that's out there. And then we looked at specific groups. You know, this is all comers. We took a bunch of melanomas and a bunch of moles. Then we took a separate group where we wanted to ask specific questions where this really put it to the test. And one group was the group I kind of alluded to before, melanomas that are growing out of a mole. And it was even better in this group. Sensitivity and specificity were over 95%. And then there are two kinds of moles that can be very problematic for pathologists to diagnose. One of them are called Spitz nevi, and these happen a lot of time in children. And the other one are called dysplastic nevi, very irregular looking moles. And these are the two ones that if pathologists are going to miss, these are going to be the two. So the point was, how good can these markers be for these two tough ones? And they were able to identify about 95% of the cases. And then the last group that we looked at were what we called misdiagnosed cases. So these were cases where a pathologist had initially given it a certain diagnosis, mole or melanoma, and then at a later time, that diagnosis was reversed because more expert pathologists looked at it, or because something grew or spread and it was clear that it wasn't a mole, it was a melanoma. And so we wanted to know, these were the toughest cases. This is what's out there in the real world, cases that are difficult and the pathologist has actually missed them, the first pathologist. And how often would the markers have gotten these right? And of the cases where a pathologist got them wrong 100% of the time, 75% of the time, the markers would have pointed the right way. So that goes to the question I was addressing at the beginning, which is it helping you? Is it better than what's out there? Is it better than what we already have? And this suggests that if we had this side by side, we could maybe prevent some, maybe most of the errors that could occur from just looking at the slide under the microscope. Now, the next thing that I wanted to talk about is the prognostic acid. And we took some of the same markers actually in a new one called NCOA3, and we looked at about 400 cases that we had developed when I was at UCSF and collected, and many of the patients here contributed to this. And so when we're looking at prognosis, we're trying to predict outcome, what happens to melanoma. And so we're looking at two outcomes here. The first one is what we call disease-specific survival, which is death due to melanoma. Is a patient dying, and are they dying of melanoma? And the second one is what we call sentinel lymph node metastasis. Is it spreading to the lymph nodes or not? Because that's obviously a very important event in melanoma. So we wanted to see, do the markers predict these two events? And we started with our 400 cases from California, but then we also took another subgroup, which actually Val helped me collect from collaborators that she actually put me in touch with. And we got another almost 150 cases from Germany. And we identified kind of a low-risk group where all the markers were down, and then a high-risk group where the markers were up. And the question is this telling us anything about what might happen to the patient? And so first you look at what the markers tell you on their own. So if the more markers we had up, the higher the risk of lymph node involvement or spread to the lymph nodes. So for instance, in the second bullet, if a patient was in the low-risk category as defined by these markers, the risk of it going to lymph nodes was only 5%. But if they had all of them, it was 30%. So it's a 6-fold increase in the risk just because of the markers. And then we looked at the patients, in terms of the death due to melanoma, and those patients where the markers are low, 96% of them were alive 5 years. Almost 100% prediction of survival in the low-risk group. Whereas if they're in the high-risk group, this was a 60%. Big difference in the risk of survival. And so the key with these types of things is, okay, that's good. We call that univariate analysis. But then you want to know, are these markers better than what we already have and what we're already using? And that we call multivariate analysis. So, you've got to compare it with what's already out there. And so when we look at predicting lymph node metastasis, we're comparing a whole bunch of things. Age, I mentioned the clinical factors, age, location, and also the gender of the patient. And then 3 histological factors, thickness, ulceration, and the Clark level, which refers to the depth of penetration of the melanoma. And we're looking at 2 statistical things. So again, a couple of definitions. Chi-square value, basically what you have to know is that the higher chi-square value means that is a more powerful marker. So we've ranked it by highest chi-square value and coming down. And a p-value is another statistical test or estimate that give us the degree of statistical significance, but here it's the opposite. you want the lowest p-value. That gives you the greatest statistical significance. So what we found was that in the prediction of the lymph nodes, our multi-marker score came in number 2. Actually, age was the best one, but it then beat out thickness, which is the main really parameter we use to recommend lymph node biopsy. So it's actually better than the best predictor, but age did beat it out. Then when we look at, disease-specific survival, this was the top factor in the analysis. So it had the highest chi-square score and the lowest p-value, and it beat out all of the other markers. And that's really the first time in melanoma that any kind of molecular marker has trumped these histological markers. And then some of you may know that as of 2010, we're using another histological factor called mitotic rate in the staging classification. It refers to how many sort of cell divisions are going on in the melanoma at a given time. And so this is also a very powerful marker. So we said, okay, let's put that into the model and see how our markers do. And it still was the top factor, even when you include mitotic rate. And then we said, let's have some real, put a real test. And we actually put the lymph node status, the sentinel lymph node status. So whether the patient has lymph node involvement or not, that's really the dominant prognostic factor that we've ever had for a patient with a primary melanoma on the skin. So that's the most important thing we want to know. Has it spread to the lymph nodes or not? And so we wanted to know, do the markers still tell us something, even if we put information about their lymph nodes? And it turned out that the markers are still significant, and in fact they beat out the lymph nodes in terms of the significance. This is something that still has to be proven elsewhere, but at least it was very promising. And then we wanted to look at our German patients and our German colleagues group, and it turned out that the markers again were superior to the routine factors that we use. So this was good that we could validate these results in a completely independent data set. So the question as I wrap up, how could we use these markers to help make decisions? Well, in terms of the diagnostic, we could apply them to difficult to diagnose cases. And again, now we can turn something which is a little bit impressionistic, because right now I would say to the patient, well, my pathologist says this, and maybe UCLA's pathologist says something else, and my pathologist is better than your pathologist, or something, and we don't want to get into that. And they're all good, but I mean, we don't really have a way of assessing this information in a statistical way. And we can get to a point where we can provide more probabilistic estimate to the patient about what we think is going on. And in terms of the prognostic, well, we can use it to select which patients should have a lymph node biopsy. We could use it to select which patients maybe are high risk and maybe would want to get interferon, and we're going to hear about that later. And the opposite, we could potentially use it to identify low-risk patients who wouldn't benefit from any treatment. I mean, if somebody's in that 96% survival group, it's hard to make that survival any better, especially at the cost of some toxicity or side effects. So, a couple of what I hope are pretty pictures. And so we're just going to focus on the left-hand side. These markers, one of the cases where we don't really know when to do a lymph node biopsy or not is if it's a very thin melanoma, under 1 millimeter. And here was a patient who had a very thin melanoma, and we didn't do a lymph node biopsy because we didn't have any indication that this person should have it. And a few years went by, and this patient developed lymph node involvement, metastasis. And when we developed the markers, we said, well, let's go back and look at the original melanoma and see, did it have these markers? And so basically, all of these brown areas, this is the melanoma, and you can see that it's chock full of both NCOA3 and also SPP1. So the point is, the melanoma knew what it was going to do, but we didn't know what it was going to do, and hopefully some of these newer pieces of information can help us see what's going on in a patient who basically should be cured of their melanoma statistically, except for a few percent. And maybe we can catch who these few percent are. And here's another case, what we call a desmoplastic melanoma. This is a very rare type of melanoma, and it doesn't like to go to lymph nodes. It usually doesn't go to lymph nodes, and what we wanted to see was, when it does go to lymph nodes, in fact, some experts have said, don't do a lymph node biopsy on these patients, because they never go to lymph nodes. And we don't really operate that way because there's a small percentage that does, and we really don't know who they are. And when we've tested the patients who had a desmoplastic melanoma, who then had a lymph node involved by the melanoma, we see that these markers are there and they're present. So we could identify which ones we think are capable of going to the lymph nodes and then really looking at those particular patients. And so my last slide is what we're beginning to do is fill in the gaps in our knowledge about what are the markers that can sort of basically underlie these various but very important transitions in melanoma progression. Thank you.